This is Hands-On News, and I'm Dr. Dimitrios Kostopoulos, and today I have with me Dr. Jonathan Kirschner, who is Assistant Professor of Interventional Spine and Sports Medicine at the Department of Rehabilitation Medicine at the Icahn School of Medicine of Sinai Medical Center. Good evening and welcome.
Thank you for having me.
Thank you for joining us today. And Rehab medicine is an upcoming field and an ever-evolving field. A field that gives the opportunity to people to get better without the use of too many drugs also. So when we talk about rehab medicine, what is rehab medicine in general as an idea for our viewers?
Sure, and that's a great question. The way I explain it, most people when they think about medical specialties, they think about a body part. So you're a heart doctor, cardiologist, you're a stomach doctor, gastroenterologist. Our focus isn't on the disease, but on the function of the patient. So when I answer that question, I say we're function doctors. Our goal is to make people function with whatever their illness is. And so some rehab medicine doctors specialize in treating people with a traumatic brain injury. Some people treat strokes. Some people treat people who have had an amputation, and some rehab medicine physicians prescribe artificial limbs. Some specialize in spinal cord injury, and some, like myself, specialize in more spine and sports medicine. So the rehabilitation would involve often physical therapy, occupational therapy, speech therapy, sometimes cognitive rehabilitation,
right.
Thinking about memory and how we think about things. Sometimes it involves medicine, although yes, we tend to use less medicine and try to take a more holistic approach, with minimal use of drugs, but we use them when needed. Sometimes we do injections. Some rehab medicine physicians are more diagnostic, and so they do nerve studies and other studies. So it's a broad field.
But at the end of the day, when a patient comes in to see you the same way that they come to see me, yes, they suffer from pain. There is no question about that. But there is also a greater concern in terms of what are the things that they can no longer do in their daily lives because of the pain, because of the limited movement that they have. As you say, function is very important, and perhaps the other fields of medicine has not paid enough attention to the function part.
I think you're absolutely right. A lot of times we think about things in medicine are very concrete, and what's your pain score? We need a number. We need to show that we can reduce that number. But for us, really, it is more about the function. So even if you have pain and I can't lower your pain, but now you can get dressed by yourself, you can go to the bathroom by yourself, to me that's a great functional success. And other fields of medicine are starting to realize the benefit of rehabilitation medicine. With the new healthcare plan, there's more integration of rehabilitation as part of one of the continuums of care. People are realizing sooner, a lot of other doctors want to cut length of stay in the hospital, and they realize that involving a rehabilitation medicine physician early on helps reduce length of stay because we can think about these functional aspects, getting people home, living independently. That's really our goal.
Sometimes, especially when I speak with orthopedic surgeons, I talk to them about the importance, not in every single patient, but in many cases, to actually start a rehab program before even the patient goes into surgery. And the results and outcomes can be much better. What are your thoughts on that?
I think it's a great idea. Some people have called that prehabilitation, and there have been studies showing that people who do exercises beforehand end up with shorter length of stays, better surgical outcomes, more functional improvement, and they're just overall happier with their treatment. The issue is somehow trying to find a way to get people into rehab before surgery, whether it's with the insurance companies and other things like that. But it definitely, and I stress that with my patients, if I know they're going to have surgery, I counsel them beforehand. Here are some exercises and things you can do to sort of tune yourself up beforehand.
Excellent, thank you. And I know that we share something very common, which is a great interest in the area of electrodiagnosis and the area of musculoskeletal imaging. And the correct diagnosis on a patient's neuromusculoskeletal condition is paramount in order to decide on the proper management. And advances in the area of ultrasound technology have created new opportunities in the field of rehab medicine. Can you tell us a little bit about the use of musculoskeletal imaging, I should say neuromusculoskeletal imaging, in rehab medicine? How do you specifically use it?
Sure. It's really important, as you said, to have a correct diagnosis. And based on that, we tailor the rehabilitation program to each individual patient's needs. As much as I am a rehab physician and I love rehab, I don't want to waste a patient's time either. If they have, unfortunately, a more severe condition that's not amenable to rehab, I don't want to waste their time with that either. I'd rather have them see the appropriate person, whether it's a surgeon or otherwise, to have more definitive care. So ultrasound technology has really changed our field, and it's changing medicine as a whole. I'm actually on a committee here looking at the use of ultrasound throughout the hospital. It's amazing to look around the room and see cardiologists, gynecologists, ear, nose, and throat doctors. Everybody's using ultrasound now, but it's really great because you can see things that, even at a higher resolution than MRI in some situations, and you can see things dynamically. So for example, if you take a static image of an MRI, a nerve may look relatively normal, but when you move the patient dynamically and you look with the ultrasound, you can see that nerve being pinched in certain positions. Then we can counsel our patient, don't keep your hand in that position.
And all that without the fear of radiation exposure that we have, let's say, in a CAT scan.
Sure.
A patient. Let's explain in simple terms for our viewers. Let's suppose that somebody, especially during summertime, they are playing lots of tennis, and they end up having a little bit of pain around their elbow, indication of some problem, perhaps some inflammation with the tendon there. What can you do using ultrasound imaging?
Sure. So one of the things we worry about, is there a strain, tendinitis, is there inflammation, is something actually torn? So the ultrasound is really good at, first of all, just pinpointing the area. Sometimes it's hard to localize where the problem is. And as I'm scanning a patient, as I'm pushing down, I say, does this area hurt? Does this area hurt? And you really have a window into the body. Some people describe it as the stethoscope of the 21st century. Mm-hmm. So I can see exactly where the problem is, and then we can differentiate, is this torn? Is it just a strain? Is this something, even though it just recently happened, maybe it's really a more chronic problem?
So this is then, we use it then as a diagnostic tool first, to be able to help us towards a more accurate, more precise diagnosis, along with the clinical examination and anything else that we do. Can we use it as a treatment tool and something that can help us in our treatment approach?
Sure. There's a different type of ultrasound which has been used for many years, which is a deep heating modality, but specifically talking about diagnostic ultrasound, absolutely. One of the conditions I use it for is patients with knee pain, for example. A very common cause of knee pain is patellofemoral syndrome. And one of the risk factors is weakness of one of the particular muscles called the VMO. And a lot of patients aren't able to activate or fire that muscle properly. So what I can do is I can scan the knee, show them the picture of the VMO on the screen, tell the patient to contract their leg. And sometimes when they initially contract, you don't see the muscle moving. We train them, whether it's tapping or touching and other techniques, for them to better activate that muscle. Then they see on the screen that the muscle moves, and it's a form of biofeedback, basically.
How about in cases where you may use to do, let's say, some sort of injection on a patient? Can you use that ultrasound imaging to help you for a more precise injection?
Yes, ultrasound is really important to help guide needles into the proper position, especially when we're doing injections in certain areas where there may be blood vessels or nerves, and so you want to make sure you're doing it very safely and effectively. Some of the injections we do are for diagnostic purposes, so we want to numb up a specific area, and if that relieves the patient's pain, then that tells us that's the source of the pain. So if you're not accurate, how do you know you've numbed up the right area or what you're really treating? So it's really important for safety reasons. There's no radiation, so anyone can have it, whether you're pregnant, if you have a pacemaker. So it's really changing the way medicine is practiced, really.
Thank you. And a topic that I know that you have published on, I've read your article, it has to do with some sort of pain that can derive from the sciatic nerve. When that nerve can be entrapped in a specific muscle in the butt, which is called piriformis muscle. So I'm talking about the case of a piriformis syndrome. Let's explain a little bit for our viewers what a piriformis syndrome is all about.
So the definition of a syndrome is a constellation of symptoms. And so the person who originally described piriformis syndrome was Dr. Robinson back in 1946. So he described the syndrome of a patient who fell onto their buttock, had a sausage-shaped mass, was tender at the buttock, had some atrophy of the buttock muscles, and had a positive straight leg raise. So now people aren't as strict when they follow that diagnostic criteria, but as far as I'm concerned, that's what piriformis syndrome is. It's a patient with buttock pain traveling down the leg. A lot of people have buttock pain alone, and that can be referred from the piriformis muscle itself. But the true piriformis syndrome was supposed to be indicative of the muscle actually compressing the sciatic nerve. What we've learned now that we have MRIs and other more advanced imaging is we realize most cases of sciatica are due to a herniated disc or spinal stenosis or a problem in the spine itself and not a problem in the buttock area.
Now, is there any possibility for an anatomical, not anomaly, but maybe variation in the distribution of the nerve that perhaps can be more of a risk factor for a piriformis syndrome? So
with piriformis syndrome, the idea is that the piriformis muscle presses on the sciatic nerve, which runs just anterior or in front of the muscle. About 20% of patients, that sciatic nerve bifurcates or divides right at the level of the piriformis or even going through the muscle. So it was thought that that anomaly or variation would be responsible for more cases of piriformis syndrome.
Is it indeed the case?
No. Theoretically, it makes a lot of sense, but in actuality, not
it's
necessarily.
Not really. And like, are there any activities that people may engage in that can exacerbate that type of pain?
Sure. If people who have a true piriformis syndrome, there's certain risk factors. People who tend to do a lot of side-to-side motion, so people who ice skate, cross-country skiers, people who run and have some sort of asymmetric loading onto that leg, so either a leg length discrepancy or flat feet, which internally rotates your hip. These are all risk factors for piriformis syndrome. Thinking back to Dr. Robinson, a fall onto the buttock, which can cause swelling and irritation of the nerve, can also do it.
A final question, or almost final question. I know that you're doing a lot of interventional techniques for the spine. So, correlation between back pain and smoking.
Huge correlation. One of the major causes of back pain in the US at least, or worldwide, about 40% is degenerative disc disease. And our discs normally are filled with water and they cushion. And so smoking really dehydrates the discs and it decreases the blood flow to the disc, which already is a structure that doesn't really have a great blood supply. So there are very strong correlations with smoking and back pain. I urge all my patients to stop smoking as soon as possible, not only for your back, for your lungs, your heart, your overall health. Even if you don't care about it, I'm sure there's a loved one in your family that really would want you to quit.
Absolutely. So, back pain, quit smoking. A few final words as words of advice pertaining to the rehab profession. Anything you would like to tell our viewers?
Just if you have any pain in your muscle, bones, joints, if you'd like to improve your function, seek out the help of a physiatrist or rehabilitation medicine specialist. We're team-oriented physicians, so we like to work in teams, whether it's with physical and occupational therapists, with other doctors, surgeons. Find out more about it.
Dr. Kirschner, thank you so much
for
joining us today. Thank you for all the valuable information, and definitely soon I would like us to get together again and talk a little bit more about the interventional techniques for the spine.
Sure.
Okay?
I'd be happy
Thank
to.
you. This is all for us for tonight. We'll be with you next week. Until then, good night.